Hi, this is Tammy McClish. Let's go ahead and take a look at section 3, and this is the basic X-ray tube design and the controlled formation of X-rays. Now, when we're looking at the X-ray tube construction, the very first thing we want to take a look at is the protective housing. The protective housing is a lead-lined metal container into which the X-ray tube is fitted. The protecting housing guards against excessive radiation exposure and electric shock. Some protective housing actually has a cooling fan to air cool the tube or the oil, and the oil is inside the X-ray tube and it serves as an electrical insulator and thermionic cushion. Now this is an X-ray tube that is being replaced. And don't be surprised if you're working for a physician's office and they tell you that the X-ray tube needs to be replaced, because it's something that does tend to happen, especially if you have a very high volume. Now, the reason that we like to keep an eye on our X-ray tube is we want to make sure that it does not have leakage radiation. So every couple of years, you're going to have the Ohio Department of Health come out, and the Ohio Department of Health, or if you have an engineer that comes out, they're going to check for leakage radiation. A properly designed protective housing should reduce the level of leakage radiation to less than 100 gray per hour at 1 meter when the tube is exposed at maximum conditions. So for most physicians' offices, you're probably not going to be using it at maximum conditions. But if you're in a very large practice, you may tend to hit high levels of radiation, especially if you are X-raying bariatric patients all the time. Now, you cannot see leakage radiation, and that's the problem, because we can be exposed and we would not even know that. So it's important to have your X-ray tube checked every couple years or so. Now, the X-ray tube housing is actually going to cover up the inside components. One inside component is a glass or metal enclosure. The X-ray tube that is glass is actually made up of a Pyrex glass, and it's a near complete vacuum. It's going to allow for more efficient X-ray production and longer tube life. The thickness of the glass is the same throughout, except at the area that's called the port, and we're going to talk about the port in a few minutes. But if you think about Pyrex glass that you have in your kitchen, it makes sense that we would use Pyrex glass as the enclosure for an X-ray tube. Now we're going to be learning a lot about the X-ray tube. We're going to start very small scale, and I'm going to be building upon this as I go through the various lectures. So anytime that you walk up to an X-ray tube and you are standing in front of the table and the tube is in front of you, when you put your right hand up to touch the X-ray tube, that is going to be the X-ray tube cathode. And the cathode is the negative terminal. Now, if you see a negative on your tube, then you will know that that is the X-ray tube cathode. It is the negative side of the X-ray tube, and it's going to contain what is known as a filament and a focusing cup. And we're going to go more into that in a little bit. But if you look underneath the term cathode, on the right hand of your screen, below it you're going to see the filaments. As you see, there's two there, and they're enclosed in a metal shroud. The X-ray tube anode is the positive terminal. Once again, if you walk up to the X-ray tube and you put your hand up to the left and you see the positive, that's always going to be the anode. It's a positively charged side of an X-ray tube that contains the target. And below that picture of the anode, you see the X-ray tube target. And we're going to talk a lot more about that in a little bit. When we were looking at the Pyrex glass, I was talking to you about a term called the port. We also call that the window. That is the thin section of the glass envelope through which the useful beams are going to emerge out of the X-ray tube. And that is very, very thin. Your X-ray tube also has filters. The filters are needed to remove low-level X-rays from the useful beam with aluminum or another metal. This filtration results in increased beam quality and reduced patient exposure or patient dose. So it's very important for your X-ray tube to have some filters. Now the first type of filter we're going to talk about is inherent filtration, and that's the picture all the way to the right. An inherent filtration is filtration of the useful X-ray beam provided by the permanently installed components of an X-ray tube housing assembly and the glass window of the X-ray tube. Inherent filtration tends to be about 0.5 millimeters of aluminum equivalent. And the reason we call them aluminum equivalent is because sometimes it's not aluminum, so we say aluminum equivalent. And in this particular X-ray tube, it's actually showing you 1.5 millimeters of aluminum equivalent if you're operating that tube at 80 kVp. So if I'm taking a hand X-ray, that's going to be about 50 kVp. But if I'm taking a belly X-ray, that's going to be about 80 kVp. The other type of filter we have is added filtration. It is a thin sheet of aluminum positioned between the protective X-ray tube housing and the X-ray beam collimator and is the usual form of added filtration. The reason we add filtration is to decrease a patient's skin dose. And then the total filtration is going to be the inherent filtration plus the added filtration, which should be 2.5 millimeters of aluminum equivalent. Now the picture that you're seeing all the way to the left are different types of added filtration. So some X-ray tubes, there's going to be a dial on the tube and you can change the dial. Some tubes you can actually pull the filter out and push it back in. So depending upon the tube will depend on the type of filter. Most often you're going to leave these filters alone. Now, when I worked in the hospital and we were doing special procedures, we would change those filters. But for your situation, you're not going to need to change those filters. Now, this is a filter that you might use, and this is called a compensating filter. There are leaflets, and these leaves are made of lead that are at least 3 millimeters thickness, which work in pairs and are independently controlled, allowing both rectangular and square fields. The very first picture you're seeing is a wedge filter. The wedge filter is principally used when X-raying a body part that varies considerably in thickness, like the spine, or in this case, a foot X-ray. So you're going to use this filter because what it's going to do is it's going to help you maintain the image quality, and it's going to compensate for the differences in subject radiopacity. So in this case, when we're looking at an X-ray tube, as you see, we're going to have radiation coming out from the X-ray tube anode side, which is on the left, and the X-ray tube cathode side, which is on the right. Now, we haven't talked about it yet, but in a little while, we're going to talk about the intensity of the X-ray tube. So let me just talk about it real quickly here. When I am looking at the X-ray tube intensity, the cathode side is going to receive a higher intensity than the anode side. And because of that, we are using this filter, this wedge filter, to decrease the radiation that is going to the toes on this patient. Now, an X-ray beams that are coming out of the X-ray tube are not going to be the same intensity. Let me say that again. The intensity of the X-ray beam is going to be higher on the cathode side than on the anode side, which in this case on the foot, it's great because you want more radiation on the X-ray tube on the heel side versus the toe side. However, to make it look the same throughout, you can put this wedge filter underneath there and it's going to give you the same densities throughout. So that's one type of filter you can have. The middle filter you're seeing is a breast filter and a gonad filter. And this is used when you are X-raying a patient for a scoliosis series. and that is just filters that are put on the X-ray tube head, and it is going to filter the radiation around the breasts and around the gonad. And then the one to the right is a trough filter. A trough filter is a bilateral wedge filter, which we sometimes are going to use on a chest X-ray. So for the most part, you're probably not going to be using these filters, but if you are using them, just know that it does improve the overall quality of the image. Now, one thing we're going to have to do is we're going to have to collimate our image. So when you're looking at this collimator assembly, there's different numbers on there. Now, if I'm taking a chest X-ray, I'm going to be shooting the chest X-ray at 72 inches from the patient to the X-ray cassette or the image receptor. Well, from the X-ray tube to the image receptor is going to be 72 inches. So before I go in the room with this collimator assembly, if I'm shooting a chest X-ray, I'm going to turn those knobs to 14 by 17 because the chest image should fit on a 14 by 17 image receptor or cassette. So I'm going to turn those knobs. I'm going to look at the 72-inch line, SID, and I'm going to turn those knobs to 14 by 17 and then go in and X-ray the patient. I'm not going to open the knobs all the way up as high as they can go, because look at what happens when you do that. If you're standing behind the X-ray console and you're trying to hide, you're going to get hit from scatter radiation. When we decrease the exposure to our patient, we decrease the exposure to us. So you want to use collimators. Collimator shutters are leaves or leaflets made of lead that are at least 3 millimeters thickness, which work in pairs and are independently controlled, allowing both rectangular and square fields. So please, please, please make sure that you collimate to at least the cassette or the image receptor. Now, if I was going to have a hand X-ray, I know that a hand X-ray is usually a 40-inch source to image distance. So I would look at 40 on this X-ray tube collimator assembly, and I would turn the leaflets from the 40-inch line to probably about 8 by 10. And then when I get the patient in the room, I'm going to collimate it a lot tighter. And that'll give me better quality, decrease radiation dose to the patient, decrease radiation dose to me. And it's all about us. It's not about, well, it is about the patient, but make sure that we protect ourselves. Now, when I go to work in the hospitals, I don't go all the time. I probably go about once a month. Sometimes I go like 5 days a week. It just depends on my schedule. Back in the day when I first started taking X-rays, we were told that all X-ray machines had to have PBL, positive limiting device. PBL is the feature of a radiographic collimator that automatically adjusts the radiation field to the size of the image receptor if you are using a bucky, if you are using a table bucky or an upright bucky. Let me tell you, these things are broke. Quite a bit they are broke. I have one place that I work that in order to get this to work correct, I have to lower the X-ray table about 1/4 inch to make it work. I have one that on the upright, I have to lock the film in place and then unlock the film and then it will work. It's weird. In fact, I had a fight with the radiologist one day and he said, "Why are you not collimating?" I said, "If you look at the first image, it's not collimated." But then once I realized that you never fix your machines, I went back and I fixed it. So you should have PBL. PBL is a great thing when it works. Now, I will tell you also that there is a key on your X-ray tube, and sometimes people will override the PBL. If you go back and turn the key, then it may fix the PBL. So on this tube, the key is in front, but most tubes, the key is in back. Just got on my soapbox. Now I'm going to have to get back off and keep going. Okay, so let's continue with some beam limiting devices. Now, some of these are very old and we don't use them anymore. Just like this. This is a fixed aperture or an aperture diaphragm. Now, when I performed angiography, we did use this, but most likely you're not going to use it. It is a device, well, any beam limiting device is a device that produces a means of restricting the size of an X-ray field. Now, there are three that we're going to talk about. We're going to talk about aperture, cones, or cylinders, and variable aperture collimator. Now, the reason that we want to use these is because they're going to increase image quality, decrease patient dose, and decrease scatter radiation. So you really want to make sure that you are using these devices. If you're using a beam restricting device, you want to use it only when the tissue being examined should be X-ray. And you want to use it when the X-ray fields result in more scatter radiation and image contrast is going to be decreased. Now this right here is a fixed aperture or aperture diaphragm. It is the simplest of all beam restricting devices. It is basically a lead or lead line metal diaphragm that is attached to the X-ray tube head. We actually use these in angiography, and we sometimes call it a keyhole. And what we would do is we would slide it in the X-ray tube, right underneath the X-ray tube, and what it would do is it would restrict our beam. So if we were going to do a skull for angiography, we would use this all the time. It's been years since I've used one of these. There's also cylinders and cones, and these are modifications of the aperture diaphragm. A cylinder is the most common type used, and then a cone is a circular metal tube that attaches to an X-ray tube housing to limit the beam shape, beam, B-E-A-M, beam size and shape. They're routinely used in dental offices, but here's the problem. When I worked in dentistry, if I did not have this cylinder pointed right to the film that was in your mouth, I had something that was called cone cutting. And that caused me to only see half of your teeth and not all of them. So if you ever hear the term cone cutting, it just means that your tube is not aligned to your film. But that was a term that we use with cones and cylinders. But X-ray techs and GXMO still tend to use that term. Now this is what you're going to be using. You're going to be using a collimator, which is variable aperture device. This is a device used to restrict the X-ray beam size and shape. It is the most commonly used device in modern radiography that reduces the patient radiation dose and improves the contrast radiation. You need to make sure that you collimate tight. I like to collimate to just toward the edge of the skin line. So if I'm X-raying a hand, I don't want to cut off skin. I want to go just outside of the skin line. Okay, now how does the X-ray tube work? All right, so a little bit ago we talked about the cathode. So if you're standing in an X-ray tube and you put your right hand up, that's the cathode. It's the negative filament. Now, when we talk about the term cathode filament, it's the part of the cathode that emits electrons resulting in a tube current. We all have light bulbs in our households. We have those curlicued light bulbs, and we have the light bulbs that we have in our bathroom, and those are the nightlight bathroom light bulbs. And it's basically a filament. And this filament has electrons sitting on it. Think of it as like dust. It's just electrons that are sitting on these wire filaments. The filament in an X-ray tube is a coil of wire. It's going to measure 2 millimeters in diameter, but it's either going to be 1 or 2 centimeters in length, and it's made of thoriated tungsten. Now what you're seeing here is an assembly that has a small filament and a large filament. So the small filament should be 1 centimeter in length. The large filament is 2 centimeters in length. They're both 2 millimeters in diameter. This is a dual focus X-ray tube. having the small and the large filament. Now, I would use the small filament if I was going to take anything that does not have the potential to move, and I want to have nice detail. So if I'm x-raying a hand, I'm going to use the small filament. If I'm x-raying the abdomen or the chest, I'm going to use the large filament because it has the potential for movement. So that's when you select small or large filament. Now, that is going to be on your X-ray control panel as something that says MA or milliamps. So you're going to have large or small, and that's what you're going to pick. And both of these filaments are embedded in what's called a focusing cup. The focusing cup is a metal shroud that surrounds the filament. And the focusing cup has a negative charge on it, so that is electrostatically confines the electron beam to a small area on the anode. Now, I haven't talked about the anode yet, but just know that the focusing cup is negatively charged so that it can take the electron stream over to the anode. Okay? So let's talk about the anode. But before we do that, the cathode is negative, and the shroud that is around the filament is negatively charged. Let's go on to the anode. The anode is positively charged. Remember that? It's positively charged. Okay, so the anode has a target. The anode target is the region on the X-ray tube that is struck by the electrons emitted by the filament. And remember, if you're standing at an X-ray tube and you put your left hand up, that will be the anode. Now, there's two types of anodes. There's going to be one that rotates and one that doesn't. Now, you're going to know what you have, because if you take your X-ray switch and you push it, you hear rotating. You hear a shrill pitch, that's rotating. If you don't hear anything, it doesn't rotate. So let me go over that a little bit more in just a second. But let's talk about rotating anodes. The anode used in general purpose X-ray tubes is a rotating anode because the tubes must be capable of producing high intensity X-ray beams in a short amount of time. The entire rotating disc is called the target, and it is made up of tungsten, and it rotates at 3,400 revolutions per minute. Now let's think if it rotated at 3,600 revolutions per minute. That would make it stationary because the electrons would strike the same place all the time. So it is going to rotate at 3,400 revolutions per minute. If it rotated at 3,600, it would strike the same spot all the time, which would make it stationary. Now, when you go to take an exposure, you go to push the button. There's something that's called the rotor. If you put your finger on the rotor and you push it down halfway, you'll hear the whirling sound. That is your X-ray tube anode turning. The rotor button allows the rotor to accelerate to the designated revolutions per minute, and that is occurring when the filament is heating up. Once you get to 3,400 revolutions per minute and the filament is hot, it will allow you to push the button. So what I tend to do is I tend to look at my patient, especially for a chest x-ray, and I hit rotor. We call that prep. And I tell the patient to take in a big breath, blow it out. Take in another big breath, and I'm on the rotor. And then I say to the patient, hold your breath. When I see they're not moving, I push the button. That way I can make sure there's no motion. It's hard to get used to doing it. It's going to take you some time. But we call that prep and expose. The prep is rotor. You're getting the rotor to rotate. Okay, I know that was a lot. So let's take a look still at that rotating anode. Now, the rotating anode, the electrons are going to strike. When they're striking, we don't want them to strike at the same place all the time. That's where it rotates. Now, when you have an anode, the electrons are going to come from the cathode. Remember, there are two filaments. There's a small filament and there's a large filament. And we've talked about this. The small filament is the small focal spot, and it's going to be 0.1 to 1 millimeters. You want to use that when you want high resolution images. The large filament, or the large focal spot, is 0.3 to 2 millimeters, and you want to use it when the radiographic technique has the potential to generate heat. Now let's take a look at that stationary anode. It is an anode used in imaging systems in which high tube current and power are not required. It's going to be used more often in dental offices. The target is made of a tungsten alloy and it's embedded in the copper anode. So it's going to be in systems that we don't require a lot of heat, like in dental units. Okay, so let's go back to the cathode. Remember, we put our hand up to the right, we're on the cathode. The cathode is negatively charged. There are two filaments side by side. Right here, you are seeing one filament. This is a cool picture. That's why I'm using it. So remember, when we think about the filament, think of dust on the filament. Think of your dust as electrons on the filament. So we have lots and lots of electrons on the filament. Thermionic emission is emission of electrons from a heated surface, or it's the release of electrons from a heated surface or a heated filament. So there's electrons sitting on your filament. When you prep, you're going to heat those electrons up. And when you do that, you're getting ready to take an X-ray. You're getting it ready. That's thermionic emission. A couple terms that we need to know before we can move on. There's something called kV. kV is kilovoltage. So what happens is in your, let's go outside for a second. Okay, so I'm driving on the highway and I have telephone poles. And between the telephone poles, coming into a household is something that's called a transformer. So what's coming in on those electrical lines outside your house, that's voltage. Once the voltage comes into your house, it's going to come across a transformer. It's going to go into your house. Now, we cannot use volts to take an X-ray. That's way too much. So we use kilovolts. And a kilovolt is an electric potential equal to 1,000 volts. So what's coming in on your light switches throughout your house, well, excuse me, the things in your house that you plug into, those things, 1,000 volts are coming in. We can't, I'm sorry, there's voltage coming in. We want to use kilovolts. Kilovolts is an electric potential equal to 1,000 volts. Milliamps. Let's go back to that switch again. There are amps coming into your house. That's too much for an X-ray. So we want to use milliamps. Milliamps is a measure of X-ray tube current. So the X-ray tube current is going to cross from the cathode to the anode, and it is measured in milliamps. And that's the number of electrons emitted by the filament, and it's determined by the temperature of the filament. So let's take a look at that again with this picture. The X-ray tube current crosses from cathode to anode, right to left, and it is measured in milliamps. It is the total number of electrons emitted by the filament, and it determines the temperature of the filament. So if I select 100 mA, if I select 200 mA, if I am at 100 mA and I go to 200 mA, I'm asking for more electrons for my exposure. What I like about this picture too, and we're going to be talking about this later, it's showing you that the intensity of the current is going to be higher at the cathode side versus the anode side. So I'm always going to put the thicker part of the patient underneath the cathode. I'm always going to put the pillow underneath the anode. I'm going to put the patient's fat belly underneath the cathode. Ooh, this has been a lot. All right, so this is the part that I wouldn't put too much into this because I don't think there's going to be a lot on your GXMO test about this, but you kind of sort of got to understand it, okay? So that's why we're talking about it. And I'm supposed to talk to you about it. So there are anode interactions. The electrons, remember it's like dust sitting on the filament. The electrons from the cathode interact with the orbital electrons or the nuclear field of the target atoms. So those electrons are going to go over, they're going to strike the target of the X-ray tube anode. And because of that, it's going to result in conversion of electron kinetic energy, which will either be heat, which is thermal energy, and it will also be electromagnetic energy in the form of infrared radiation, which is also known as heat, and X-ray. So when the electrons leave, like when the dust leaves, when the electrons leave the filament, they strike the target on the X-ray tube anode. At the anode, you're going to have heat, you're going to have thermal infrared, you're going to have heat, which is thermal energy, you're going to have infrared radiation, and you're also going to have X-ray. And the X-ray is your useful beam. All right, so let's go on and we're going to talk about that anode heat. And the anode heat is why we have to wait between exposures, because we don't want too much heat to be generated in our X-ray tube. Okay, so let's talk about anode heat. Now, I'm not talking about the light bulb inside your X-ray tube. Because you know when you push the button and you see the light on the patient's foot or on the patient's hand, I'm not talking about that light. That is the collimator light. Now I know, especially in podiatry, if you keep pushing that light, pushing that light, pushing that light, your X-ray tube is going to get really hot. I'm not talking about that. I'm talking about electrons constantly bombarding your X-ray tube anode. It is going to cause the X-ray tube anode to get really, really hot. Now, I hate this picture, but I'm using it. The reason I'm hating this picture is because what have I been telling you all along? When you walk into an X-ray tube and you put your right hand up, that's the cathode on the right, the anode's on the left. This particular X-ray tube is flipped. So just ignore that fact, okay? But know that your X-ray tube anode is going to get hot. All right, so let's talk about anode heat. The electrons interact with the outer shell electrons of the target atom, but do not transfer sufficient energy to these outer shell electrons to ionize them. The outer shell electrons are simply raised to an excited or higher energy level. the outer shell electrons immediately drop back to their normal energy level with the emission of infrared radiation. The constant excitation and return of normal shell electrons are responsible for most of the heat generated in the anodes of X-ray tubes. Now, what does that mean? That means that we talked about this when we talked about atoms. Remember, when you have an X-ray, you have the potential to eject the electrons out of an atom. That's what's happening at the X-ray tube target. So when the projectile electrons that are coming from the cathode interact with the anode, 99% of what's going to happen in that X-ray tube is going to be kinetic energy, is going to be converted to heat, and 1% in radiation. So an X-ray tube is not very efficient because 99% of what came off that cathode is going to be heat, and only 1% is going to be X-ray. Not a very efficient system, but it works. So X-rays are going to be produced at the anode target as a result of the sudden deceleration or absorption of the electron stream. So the electrons coming off of the cathode are just going to be absorbed into the anode. The production of heat and something known as characteristic radiation, which I'm going to talk about next. So the production of heat and characteristic X-rays involves interaction between the projectile electrons coming off of the cathode and the electrons of the X-ray tube target atoms. Okay, so I'm telling you now, characteristic will not be on your GXMO test, but I just talked about it, so I think I need to talk about it again. When I'm an X-ray tech, I got to know everything about the machine, so I'm going to talk to you about it. Now, characteristic will not be on your test, but Bremsstrahlung will. Okay, so let's talk about characteristic first because it's here. X-rays are released as a result of the photoelectric effect. Its discrete energies are determined by the respective electron binding energy. So if the electron interaction with an inner shell electron of the target atom rather than with an outer shell electron, characteristic X-rays can be produced. So characteristic X-rays result when the interaction is sufficiently violent to ionize the target atom through total removal of an inner shell electron. And that's what you're seeing in the picture to the right. This type of radiation is called characteristic because it is characteristic of the target element, which is the X-ray tube target. Characteristic X-rays are created at the X-ray tube anode target when an incoming electron coming off of the filament interacts with the K-shell electron of the X-ray anode target, and it's going to knock the K-shell electron out of its orbit. When the K-shell electron void is filled with an outer shell electron, a characteristic X-ray is emitted. Movement of the electron from the L shell to the K shell results in the release of energy in the form of an X-ray photon, which is called characteristic X-ray. The photon's energy is equal to the difference between the binding energy between the two electron shells. And we kind of talked about that, and we talked about atoms a couple sections before. So if you have a kVp level of 70 kVp, which remember, okay, anytime we use a grid, we should use at least 70 kVp. If you have a kVp of 70 kVp or higher, it is required for a characteristic X-ray to be produced. Anytime we are X-raying and we are not using at least 70 kVp, there won't be any characteristic X-ray. Okay, so I kind of thought I had to talk to you about that because, you know, we're shooting a hand X-ray versus shooting a skull X-ray or a belly X-ray. You know, at 70 kVp, if you go below that, there's no characteristic X-rays. But if you go above that, there is characteristic X-ray. So I thought we needed to talk about that. Okay, but that won't be on your test. Bremsstrahlung will be on your test. Bremsstrahlung X-ray is also called breaking X-ray, and that is going to be on your left. X-rays that result from interaction of the projectile electron with the target nucleus. It's called breaking radiation. Bremsstrahlung X-rays are produced when a projectile electron is slowed by the nuclear field of a target atom nucleus. Now, we already talked about heat. We talked about characteristic. Now, this is Bremsstrahlung, and it is a third type of interaction in which the projectile electron can lose its kinetic energy, and it is an interaction with the nuclear field of a target atom. In this type of interaction, the kinetic energy of the projectile electron is also converted into electromagnetic energy. Bremsstrahlung X-rays are created at the Xray tube anode target. Okay, so it's inside the Xray tube. When an incoming electron, which is the electron that comes off of the filament, when an incoming electron misses all the electrons of the Xray tube anode target and gets very close to the nucleus, then suddenly slows down and abruptly breaks and changes the direction. The kinetic energy of the electron motion is converted into an X-ray photon. The photon produces a small bundle of electromagnetic energy. An X-ray formation by this interaction is called Bremsstrahlung, which is German for breaking radiation. You will have Bremsstrahlung radiation as low as 1 kVp. Now, the lowest kVp I use is 20, and that's for a mammogram. For a hand X-ray, the lowest I'll go is 50. For a belly, maybe 70 to 80. Highest I'll go is like 120, 130. So if you are operating an X-ray tube at 100 kVp, which is probably what I would do for a chest X-ray. So if I'm operating an X-ray tube at 100 kVp, 15% will be characteristic, and 85% will be Bremsstrahlung radiation. All right, I know that was a lot, but that's it for this particular section. So go ahead and have a good day.